Hello, everyone, and welcome to the AMSA Town Hall on Reproductive Justice and Medical Education. I'm Aaliyah Runyon. I'm an OBGYN and abortion provider, as well as AMSA's reproductive health strategist. It is no coincidence that today is International Safe Abortion Day, and safe abortions don't happen without trained providers. For too long, medical education on abortion care and family planning in this country has been lacking quality curriculum and clinical experiences teach medical students and residents the basics of abortion and contraceptive care. Abortion is life-saving, common, and normal, yet many medical students have never learned about it in a classroom or participated in abortion care clinically. Most curricula on the subject are opt-in, so the default option is to not receive this training. However, there are many clinical rotations on subject matter that affect far fewer people than those who might need to terminate a pregnancy, and this is about 50% of the population. AMSA's Reproductive Health Project began in 2019 with a generous grant from an anonymous donor with the overarching goal of increasing the quality of medical education experiences in abortion care available to medical students, introducing medical students to concepts of reproductive justice, liberatory medical education, and recognizing the humanity of doctors in training, as well as our patients' right to their own bodily autonomy, as well as holding our medical institutions accountable for providing a comprehensive medical education to our future patients or to our future physicians. We will soon be releasing a white paper discussing the results of our survey of over 1,500 domestic medical students, which replicates previous surveys over the past 30 years, showing overall deficiencies in reproductive health and abortion care education throughout domestic US medical schools. Medical Students for Choice, represented here by Executive Director Pamela Merritt, was founded 30 years ago at UCSF by Dr. Jody Steinauer, an OBGYN and fellowship, complex family planning fellowship director, while she was in medical school to address this same need. 3 decades later, MSFC has added to the quality and quantity of abortion care educational experiences, as have some medical schools. However, the repeated call to improve access to this training from students and faculty alike have not resulted in standardized abortion care medical education across the board. For example, in 2005, a survey of about 100 OBGYN clerkship directors, 17% of those directors reported no formal education about abortion either in the preclinical or clinical years. In the OBGYN rotation, 23% of those directors reported no formal education on abortion, and only 32% offered a lecture specifically related to abortion. 45% of third-year rotations offered a clinical experience in abortion care. However, participation was generally low. 15 years later, in 2019, a different survey of 160 medical students, 30% reported receiving at least one lecture on abortion during medical school, and only 58% reported clinical exposure to a surgical abortion. So in 15 years, unfortunately, the improvement in medical education on abortion care and family planning has been very minimal. There are many factors at play in making this goal a reality, but one of the first steps is to recognize much of the effort, organizing, and behind the scenes labor, in addition to learning medicine, has been squarely on the shoulders of medical students. While trainees have risen to the task of improving medical education for future generations, each student deserves the opportunity to better their own experiences. This is liberatory pedagogy. This requires accountability on the part of medical schools to advocate for appropriate and necessary medical education and abortion care in spite of efforts at the state and local levels to squash these opportunities. Our panel tonight will discuss their experiences and perspectives on efforts to improve and increase access to abortion training as a life-saving and necessary skill, as well as incorporating the principles of reproductive justice into reproductive health education. I am proud to present our friends, colleagues, and panelists. We have Dr. Kristen Brandy, who is the board chair of Physicians for Reproductive Health and a founding member of Centering Equity, Racial, and Cultural Literacy in Family Planning, otherwise known as Circle FP. Dr. Cherie Sloter, Assistant Professor, Department of OBGYN at Michigan Medicine, as well as the Program Director of the Complex Family Planning Fellowship. And Pamela Merritt, as mentioned, the Executive Director of Medical Students for Choice. Welcome, and thank you all for being here. Dr. Brandy, I'll pass it to you to introduce yourself.
Sure. Hi, everyone. Lovely to be here with you all. Dr. Kristen Brandy, pronouns she, her, aya. As was mentioned, I'm the board chair for Physicians for Reproductive Health, which is an organization that helps physicians speak out on behalf of the communities that we serve. I also work with Centering FP or Circle FP to work on bringing racial justice, critical race theory, and other important frameworks into reproductive health care. I'm helping people understand that so we can better serve our communities as well. And lastly, hot off the presses, I'm working with the Ryan program to help build an abortion training network across the country. And so we'll talk a little bit about that as we're talking about how are we going to actually make sure that everyone that needs it will get the training to be able to provide this care.
Thank you so much, Dr. Loader.
Hi, everyone. I'm Sharice Loader, she, her pronouns. I am faculty at University of Michigan. My interests are in medical education and education for medical students, residents, and fellows in abortion training. I am interested in bringing reproductive justice education to medical schools and medical students. And I was fortunate to work with reproductive justice advocates to help start the building blocks of a curriculum, and have been working with AMSA on producing an elective in reproductive justice and autonomy for visiting and University of Michigan medical students, which I'm really excited about. And as things are changing around our country, also getting a lot of requests for abortion training from outside learners. And so navigating how we can train people at our own institution, but also invite people in even more restricted states to come to Michigan to get the training that they seek in terms of family planning and abortion care. Thanks for having me.
Excellent. Thank you so much. Pamela.
Thank you so much for this opportunity. It's a pleasure to be here, and I can't wait to hear this discussion and participate. So, I am the Executive Director of Medical Students for Choice, celebrating our 30th year. And, for an organization that began with a very focused on the United States, then expanded to Canada. We are now a global nonprofit working in over 30 countries. And our chapters keep growing. Our largest membership is North America, but our fastest growing membership is the Global South. And so I get to see the progression of reproductive justice and liberation happening all around the world. In the United States is really the outlier. I also am privileged to learn from activists all over the world who are working in environments where abortion is criminalized and where illegal abortion might be one of the top causes of death for people who are capable of pregnancy. So it is both a fascinating and privileged position to be in, but also to allow our members in the United States to learn from the activism and the medical practice that is happening all over the world, so that we tend to see ourselves as the most amazing and advanced medical environment in the world. And I think that creating a more global community to go along with the global movement for reproductive justice is key. So I was eager to join MSFC as a reproductive justice activist to infuse the framework into the organizing that we do, and then to really capitalize on our global network so that we can learn from each other and also be inspired from each other, particularly in the US where things are looking pretty rough.
Well, thank you all so much. So to get us started, my name is Anna Heineman, and I am a fourth-year medical student and AMSA's Reproductive Health Project Fellow, and I will be leading the Q&A this evening. I'm so excited to have all of you here and to learn from this amazing panel we have. So let's get started with the first question. And I will start with Dr. Brandy. So since the Dobbs decision, what implications have you noticed for medical education?
I mean, where to start, really? It's similar to the struggles that we're facing around clinical care. Medical education is only going to get worse, as we suspect, as the Dobbs decision kind of unfurls across the country. As Dr. Runyon already mentioned, we were already in a hole as far as medical education. We know that many medical schools don't have appropriate training in abortion and other types of reproductive health care. So that was our baseline. And now with abortion care being more politicized, I worry about what that looks like now for our education system. We are already seeing some of this roll out. We're seeing that people are less interested in going into fields like OBGYN because they may be worried about the implications for them matching into a program where they may not get the full experience of training, let alone recognizing that they are themselves possibly capable of reproduction and maybe matched in a place that may not support their reproductive health needs as an individual. And I think the main thing that I'm concerned about is that in this moment, the onus right now is on the trainee, that they have to figure out how they're going to get training. It's not something that is incorporated into their own education. So they have to figure out, without funding, without support, how to actually get training to appropriately care for patients. And that's a huge problem.
Yeah, absolutely. So going off of that, I am a fourth-year medical student currently applying for residency. And so this is very applicable to me and a bunch of other people going through this at the same time. What advice do you all have as a panel to medical students as they're applying for residency or residents applying for fellowship, questions to ask, things to look for, etc.? And maybe we can start with Pamela, and then if anyone else wants to jump in too.
Sure. So I think my advice is to do your research and to make sure that you are talking to people who, as many people as you can, about a program. I think it's also important to think about creative, and I'm so sorry if you're hearing dogs barking, but that it's important to think about creative ways to tap into training. So you have opportunities at MSFC to train. You have opportunities through a lot of other organizations, but you really do have to start doing that work now to make sure that that's going to be available. I think that at the bare minimum, residency programs owe medical students transparency, and you can tell a lot by what they won't say. So if you are interested and know that you want to receive training in abortion and family planning, you have to really ask the very focused question: are you going to allow me to leave the state to get this training? So if you're looking at a residency program in a state with a ban, then you need to ask them those questions, and then you need to talk to some residents and see if it's true. Unfortunately, we hear stories all the time of people who are being threatened or intimidated, that there's no support for that. So you really have to get below the weeds. And I think that's why folks are a little nervous about this environment. Residency programs could change that right now. They could unite together and be transparent. They could state what their support is going to be. So it's the same thing with medical schools, that they are in control, and the secrecy is something that they have decided to lean into with the hope that they'll be able to fly under the radar. I have some compassion for that, because I know that these state legislatures are vicious, and there's a lot of funding that goes into programs that you wouldn't even think of, and that is controlled by state legislators. But we're really fighting for the profession here, and we're fighting for the public health of our communities. So you need to ask the questions, ask the follow-up question. If they're like, oh sure, faculty will work with you, how, when, give me an example. Because as much as I want to make sure that people don't abandon the 15 or is it 14 now with Wisconsin states that that have bans, I'm also deeply concerned that people get locked into a situation that is both hostile, it's limited, and then they don't get a competitive level of training. And it's I have to admit, like, it's a little creepy to be sitting there thinking that this is all contingent upon faculty who are willing to go above and beyond for you. And that's the challenge we need to give to residency programs, that, you've got to give me something more than this. Oh, we've got our current mix is really great about this. But that's my advice.
That is such important advice. I love that. And to really be direct in your questions, and those follow-up questions are so important. And I know you talked about outside learners and that, and I know Dr. Loader, you also talked about outside learners and incorporating that in University of Michigan. So I was going to see if you had anything else to add as well.
Yeah, I think the accountability piece is so important. Thank you, Pamela, for highlighting that. My advice has always been to people applying an OBGYN to ask what the family planning educational experience will be at all residency interviews. And that continues to be my advice. I think now it's important to ask, like, what is the rotation? Who's doing the teaching? And if there's some vagueness with that answer, like, has a resident set up a contract to go to an outpatient clinic? Has that been successful? Have they been able to be trained at another residency program? Because on the fellowship director end, I see many applicants who have tried to set up rotations as residents and have been unsuccessful because of contract negotiation issues. Either the hospital won't pay them while they're gone, they won't set up malpractice insurance, it violates some state regulations or laws. So even, I think it's really important to find out if it has been done, because it is quite an onerous process to set something up for the first time, and can be held up due to a lot of unforeseen barriers. So I think it's just really important to know what you're going into. I know that the residency application process is competitive, and you may not feel like you have a choice, but you will be more educated if you ask those questions and just know how to prepare yourself for when you arrive at that program.
I love that. Thank you all so much. So I'll move on to our next question here, and maybe have this for Dr. Brandy. So what strategies or innovations can be implemented to engage medical students more effectively in abortion care and reproductive health education, and specifically when it comes to stigma around abortion care and abortion education?
Sure. And I think framing it in a reproductive justice lens is a great way to approach it. Even though I don't think it's particularly innovative, I hope it's not innovative, but it's something that I think more and more medical schools are thinking about as a way to introduce the topic. Because I think part of the problem in reproductive health training is that abortion care and family planning in general has always been like this siloed thing. It's an optional lecture, or it's something that it's definitely separate from all the other things. Like, you're learning about all the other processes in obstetrics and prenatal care, and then all of a sudden you have the separate abortion lecture. And so when we talk about reproductive justice, we're talking about this framework of reproduction and how people make those decisions, and what are the social factors, what are the systemic issues that force people's hands in making some of these decisions for themselves. And so I think one, framing it in a reproductive justice lens, we're going to talk about pregnancy and pregnancy options, not in a prenatal care and abortion as separate things, but like as an integrative conversation. And then also naming some of the systemic problems that impact people's decisions around reproduction, that it's hard to talk about, people choosing whether or not to continue pregnancy without talking about economic justice, around housing, around all these other things that reproductive justice names. And so, we have to encourage medical schools to get that more liberal pedagogy and get more into the weeds about how does all this stuff impact the patients and how they seek care, for us to better understand that. Because we're not doing a good service to our patients if we don't have that core understanding, and that should be first, second year med school classes.
Absolutely. And speaking of a reproductive justice framework, Dr. Loader, you mentioned the reproductive justice elective. Would you be able to talk about that a little bit more for med students?
Yeah, the reproductive justice elective that we piloted in the spring is a way for us to engage visiting medical students who can apply through the VSLO visiting student elective process, and enroll in a course at University of Michigan and learn from reproductive justice advocates. And I think that's the big, one big piece to highlight is that while it is very helpful to have physicians speaking about reproductive justice, it is also vitally important that reproductive justice advocates are sharing their insight, their years of experience, and telling us what's happening on the ground and how what their activism has been able to change and how we can engage as future physicians and current physicians. So what was great about our pilot is that our students were able to learn from advocates. And I think that was just it was innovative and doesn't typically happen in many medical school curricula. Another thing that I've done is video record many of the people here on this panel talking about different reproductive justice tenets. And so when I'm lecturing my students in the clerkship about reproductive justice, I can show a video of an activist or advocate talking about a certain topic, just to bring the advocate into the classroom. And I just love the ability to do that, even if I can't bring them in live.
Yeah, and if I could just jump in, so I can't say how important that is. It's just so incredibly important. I remember when I started out doing activism in my home city of St. Louis, I really reached out to nursing community and OB-GYN and doctors to come and talk with us about the issues that we're facing, particularly Black women in, economically neglected areas. And I think we lose so much if we're not talking about the whole person and the reason why they may or may not be approaching a physician, in a way that actually helps them be open and honest and get open and honest dialogue back. And I can't tell you how many times I've talked to medical students about the fact that, if you're in a state that has an abortion ban, do a little research, because I bet they're criminalizing a whole bunch of stuff about people who experience pregnancy. And so that might be the reason why somebody isn't disclosing, that they prior drug use, or disclosing that they're in a domestic violence situation, or whatever might be impacting their health. So I think I'm always mindful as a reproductive justice activist that medical students are coming from the population, and many of them have not experienced the diversity of life that exists among the patient population. So we can't assume that they know that, folks have, you might have a patient who's never been to the dentist, or you might have a patient who has had horrible experiences, trying to get basic family planning care. So, that's something that has to be a part of the education process. And that's within the reproductive justice framework. It challenges us to do that and to, not see somebody as just a potential pregnant person or, a potential abortion patient, but really to see the whole person and all of the various wonderful and things and also challenging things that contribute. So I think that's really wonderful. And I always try to speak when I'm invited to speak to students, because I think it's an opportunity to spread the gospel of reproductive justice, but also get people a little rattled, like go off campus and go into the community and see kind of what birth workers are doing and what social justice workers are doing. It really will make you into a better physician.
Absolutely. And Pamela, that was the perfect segue into my next question that I'm going to bring to you just right back. What is the role of interdisciplinary education in the RJ curriculum? And how can medical students in medical schools themselves collaborate with other professions for a more comprehensive approach?
I love this question. So for reproductive justice for me was not something I experienced or was introduced to in college. So I tend to see it as like real world RJ, and then there's academic RJ, and I like to deconstruct the barriers between the two. I think it is absolutely critical that people who are going to be treating humans study them and try to get as much knowledge about the human condition, particularly in their community. I think it's important that people who are doing sociology or anthropology or even social work are also understanding how medicine works, because I've learned more in the 3 years I've been at MSFC than I'd learned in 50 years of being a patient. And it helps me understand both the limits and the bureaucracy and the legal framework, which is where most activists tend to stop. So all of those things interconnect to create a perfect storm. So it is absolutely critical. And I will honestly say that building out that is as simple as reaching out to people who are doing the work. A great example of that would be a program when I was at Repro Action, my previous job, and we partnered with then NAPW, now Pregnancy Justice, to do a program about Wisconsin's Unborn Child Protection Act, which is really sourced in the crack baby myth and very outdated and debunked science. And it's still on the books. It's still being enforced. People are still being denied their rights because they have an honest conversation with a doctor or a social worker about drug use. And it flies in the face of all known social science, but it's real. And what we did is simply, be in Wisconsin and reach out to different people doing the work. And, where are people going to get treatment? Where are people more likely to see this information? And I'm always amazed, but I shouldn't be surprised that people were open and willing to have dialogue about the work they're doing, with harm reduction for people who are using drugs, or work that they're doing at the intersection of domestic violence and drug use and homelessness. And all of these advocates are just thrilled to discuss their work and explain how it intersects with people who experience pregnancy. I know for myself, I rarely blow somebody off because I think it's so important that people reach out. But you can't. The thing I love about RJ is also the challenge of RJ. Like reproductive justice really demands that you stand up and move forward, that you engage, and that you engage and listen and with humility and an openness to what is happening in the world around you, so that you don't just see drug use and pregnancy through like this siloed lens, but you're really seeing it as a complex public health issue that is actually being furthered and doing more damage by keeping it as like a criminal justice issue. So and I can honestly say, like, when you first say that to people, I've actually had this conversation with medical students, they tend to be like, wait a minute, well, that's bad, and then you realize, like, that is exactly what we have to deconstruct for you. But you can't get there if you don't begin the conversation and say the thing that basically has people like reacting like that. So I think, there's so much that can be learned across disciplines, and both within our educational institutions, and then also, in the real world. And it requires, unfortunately, unless you have a reproductive justice set up where you're actually creating that, like at Michigan or other schools, unless you have that, you're going to have to do some work. But it's not as hard as it sounds. And there are folks like me and other activists who would help medical students kind of walk that path. And it really does just create a more well-rounded view of fellow human beings who are capable of pregnancy.
I absolutely love that. Tearing down those silos is one of the things that we talk about all the time, and is going to be the way that we win this fight. And so that actually got me thinking, Dr. Loader at University of Michigan, and a lot of our medical students and residents are at big universities where there are opportunities for collaboration within different disciplines within the community of the university itself. Are there things that University of Michigan has done, or any tips for other students who want to collaborate more interdisciplinary within their programs?
Yeah, I think it's important to work with other departments and other disciplines. For example, like our midwifery group is really involved in our perinatal quality initiative across the state, and has been able to do a lot of work with reproductive justice through those perinatal quality initiatives. And actually, our family medicine department has led a lot of the research around urine drug testing in pregnancy and of neonates, and is changing policies at our institution. And so those are some ways other specialties or disciplines are doing reproductive justice work. One thing that I would love for our elective, if we do get to be all in person again, is that, I would love for our students to pair up with an RJ organization and, figure out, learn what the projects are that are going on, learn what it's like, to help out at an organization, and kind of what the limits may be as a student or physician in collaborating, but also finding out how we can, help that collaboration and partner. And Mothering Justice in Detroit, came to our elective and talked about Birth Detroit, which is a birth center that's being built in Detroit that's focused on providing safe care that's midwifery and doula led, and just really exciting for our students to learn about, because it's not something that they're seeing on their OBGYN clerkship.
Wonderful. And Dr. Brandy, I'll hand the floor to you too, if you have anything you want to add as well.
Yeah, I think I want to continue on with this thread. And I think while I really love all the short-term advice that Pamela has offered for students to reach out into their communities and to find these connections, to Dr. Loader's point, I think that this is not something that we should put that burden on our students to do. That part of our work in AMSA and other organizations that are involved in education is that we really need to consider how can we restructure the medical education system that naturally incorporates this. And that is, as mentioned before, like that is RJ's challenge, is to question and to challenge these structures that already exist within medical education. I'm not surprised that RJ is not part of medical education, because that would have required the people that are in charge of medical education to be familiar with this concept, to be well grounded in it, to have built their curriculums with it, which is not a thing. That's not how it works right now. And I think we need to learn a lesson from the history of reproductive health, where back in the day, abortion care was done by natural healers, people in the community, Black and brown people, to their fellow, community members. And groups like the AMA had, created this medicalized system and pushed out all of the midwives and all of the other healers. And we continue to do that through our medical education. And so this using and incorporating other, frameworks, other thoughts, other experts that have traditionally been outside of medical education should be the standard. It should be something that we are incorporating if we are indeed living out these justice principles, and really reforming what medical education can look like for the better.
Thank you, Chris. I echo all of that completely. I just want to hear from you and the other panelists about combating the stigma that's out there it's in medical education. It's patients talk about the stigma around abortion, and the general public. I mean, the general public generally votes for abortion, generally approves of abortion, but stigma is definitely out there, and it's definitely a barrier, especially as Pamela was mentioning, schools are getting pressure from legislatures and other organizations. This does not excuse them for not standing up. However, there is stigma and there is pressure. I just wanted to hear what your thoughts were.
I mean, stigma is a huge problem. And I think we've talked about how there's not a lot of people standing up for it. Like the people in this room, I think, are open and interested and are trying to speak out about it, but it's not something that's happening on a higher level, and people in power are using that stigma to keep things comfortable and to not make that change. I think we need to really analyze where the stigma is coming from. Stay tuned. I'm publishing research about how pronatalism may be impacting our feelings about abortion stigma. We need to talk about all the other things around reproductive health care, and do so in a way to decrease that stigma, because we're seeing how it affects things like gender affirming care. We're seeing how all these cares that have been marginalized and stigmatized are being impacted now and politicized. As far as how we do that, it's really by having groups like this. It's by talking about it. And I think also, again, bringing in those non-traditional, so to speak, people into this medical space, because those are the people that are seeing people on the ground, that are engaging in this work on a different level than traditional medical educators. We need to bring those people in, and we need to be having more voices of patients in these conversations, having more patient advocates, having patients involved in the education process, just like we're doing participatory research. We should be having that same framework around education. So there's different ways to approach it. I don't have a good example of who's doing it well or how we're creating that destigmatized space. But I like to think that AMSA and Medicines for Choice and organizations like this are starting to do that work to create that destigmatized space.
I couldn't agree more. I think that, sadly, losing a federal recognition of bodily autonomy has gone a long way to breaking down stigma. And it always struck me as weird in all of my years of doing this work that, more people will have abortion care than will have major dental surgery in most of these states. And yet there's this huge stigma. So the stigma is heavier and a bit and bigger than the actual encounter and interaction with abortion. So I think, that's front and center now. I've heard politicians on all sides who have not said the word abortion in all of the years I've known them say the word every day now. And, you're hearing it in the press. I was watching a news report about Kerry Washington from the show Scandal talking about her abortion. You're seeing, a lot of different people engage and challenge. And so what used to look like infighting, we used to be scared. When I first started doing this work in 2005, there was this fear that if we didn't present a united front on abortion and family planning, that it would reflect poorly on the public. And now, for me, it's like we have nothing to lose but our chains. To quote Asada, it's like we need to talk about this, and we're not going to agree on everything, but that's good, because that means we need to have robust and enthusiastic debates about how we frame abortion later in pregnancy. How do we talk about it as a policy? How do we approach these people who are trying to create drama where there shouldn't be drama? And now that the sad tragedy is that now that we're seeing real world consequences for what was, previously dogma, we now have people having real world conversations about it. And, I've overheard them. I've been a part of them where people were like, well, I never wanted somebody to be sent back to their car to, continue bleeding until they were septic. And I'm like, well, but that's the real world. And I think the opposition, people who are opposed to bodily autonomy, are actually struggling a bit on how to talk about this in the, outside of their talking points. So we should be capitalizing on the fact that abortion is front and center as a policy issue, and that, that we're figuring out how to line up and what policies make sense. And hopefully building out strategy, because I'd like to see a lot more strategy and less tactic to tactic to tactic. But I think there's a huge opportunity there. And stigma is the enemy. And, I often tell people that, if you replace abortion with vaccines, and, in a lot of the policies that have been churned out at state level, that should give you pause. What's happening politically around abortion and around gender affirming care is setting precedent for a lot of things that people don't have a problem with. And they need to understand that when you open up the door for stigma to silence rational, normal people, and then the extremists are the only voice out there, then you have people who literally pass laws to ban perfectly fine healthcare. And then you're thinking, oh, that's just them. That's it. I remember 3 years ago, these exact same extremists were talking about vaccines and that people should take the exact same medicine my dogs take once a month to make sure they don't get heartworms. So, that could be policy. Those are people in power. And if you open up the door for them to say this medical procedure, this treatment is good, this treatment is bad, and then you have a judge who's going to take an FDA approved medicine and take it off the shelves if he gets his way, that is a threat to everybody. So we are doing a service, not just to people who experience pregnancy, but we are doing a service to every single person living within earshot when we talk about the fact that this is an absolute nightmare waiting to happen, and particularly around the issue of vaccines, because so many of the banned states are the same states that didn't want to mandate masks. These are public health concerns that impact a lot of people, a lot more people than major dental surgery.
Yeah, something that I've thought a lot about when it comes to stigma is the language that we use in medical education around abortion, and really this delineation between contraception versus abortion. Is that something that any of you have noticed? And what do you think about how that has impacted the societal stigma of abortion care itself?
Go ahead, Dr. Nutter.
Sorry. I think there is this, feeling amongst students, practitioners, clinicians, that people should be contracepting if they're at risk for pregnancy and don't desire a pregnancy. And even medical students, feel like they've done something wrong if a patient doesn't choose a good form of contraception after they go in to do their counseling. And I always say that as a family planning expert, I feel less pressure to have that outcome. What I hope for in a conversation with a patient is that we have a good exchange of information and that we make a decision that aligns with their values and beliefs. And sometimes that is to not use a contraceptive method and to use abortion occasionally as they need to. And that is their decision, and that can be aligned with their preferences and beliefs. And, I have no stake in this game, and I really shouldn't feel the need to, pressure someone or have bias or, around this decision. But I think it is really challenging. I think it's challenging for people who, are working really hard towards a graduate degree, not to think about how important contraception is in their lives potentially, and not understand the lives of our patients and understand what's important to them. But, we do need to kind of gather information so we can understand what's important to our patients. And sometimes using a contraceptive method is important, and sometimes using, abortion care is important. And that is our patient's decision, and that lives with them.
Yeah, adding to that idea that I think that we have conflated within reproductive healthcare this idea of public health service as something that applies to each individual patient, when it's not actually the case. And what I mean by that is that contraception is seen as a public health tool. It is a preventative measure to prevent a bad outcome, so to speak. And so when we medicalize it in that way, I say this a lot, but we are treating birth control like a treatment. We're treating it as a treatment, a preventative treatment for something. So like we tell people, don't get lung cancer, don't smoke. So we're trying to use contraception in this preventative way to avoid this bad outcome. We're thinking that unintended pregnancy is a disease, not necessarily something that is a very legitimate thing that can happen to people for a lot of different reasons, in a lot of different contexts. That being pregnant is inherently not good or bad, in the same way that, perhaps a cancer diagnosis, heart disease, those other things we consider bad. By giving it that frame, we're like highlighting and kind of lifting up contraception as this thing that everyone should be doing to prevent said bad outcome. And we're also further stigmatizing abortion because you made it to the bad outcome, and this is the result of your bad outcome, is that you're going to have an abortion. And so I think we need to separate it from that framework. We need to say that contraception is an option for people that may want to delay pregnancy, but it's not a mandate. And that abortion is something that is, when we have that conversation about people using abortion as contraception, And people don't like to say that because that feels like they didn't prevent anything. They're doing the thing anyway. When in fact they are having an abortion as a decision to prevent the ultimate outcome of having a child that they are parenting. And so when we frame it separately, the contraception is preventative, abortion is like a treatment now for a bad outcome that happens, we're further perpetuating that stigma, and that really needs to stop.
Absolutely. And inherently, I mean, abortion is a form of contraception, right? So that in its in a way of the intended outcome. So how we really talk about that is going to be important. Pamela, do you have any thoughts that you would like to share on?
Oh, yeah, I think, reproductive justice is really a gift here because it really, centers the individual and, is impacted by reproductive oppression. And one of the biggest challenges that I had to face when I first started doing outreach into my community was all of the stigma I had towards unintended pregnancy, teen pregnancy, you name it. I was shocked at how much I harbored, and I was challenged by young pregnant women and recent mothers that I was working with, where they would I told them we're on an equal plane. So they kind of jumped up in my face about it, and it was helpful. Like the issue of bodily autonomy is that the individual needs to make those choices, and they get to. So, teen pregnancy is a problem because of the way society treats teen mothers and the supports that we don't want to give to them, as if denying people human dignity is somehow going to create a stigma for this thing we don't like so that it won't happen. But the reality is that we need to work ourselves around to supporting somebody in the decisions that they're making. And that is a long walk for me. So I know it can be a long walk for a lot of people. But my problem with the Duggars isn't that they have a ton of kids. My problem with the Duggars is that they want to impose their value system and their view of parenting and pregnancy on every single person in the country, regardless of whether we want it. And I want a world where people who want to have large families are supported and are given the resources to have healthy families. And I want a world where, people who have non-traditional families or views on that have the community supports where they can live in communities free of violence and oppression. And that centering belief challenges us to not apply stigma to a 13-year-old mother or to a 50-year-old mother. And that is hard for some people to do, but then that's the challenge. Wrap your head around it, because that's what the work really should be.
Absolutely. So now I'm going to move the topic to our next question. And so this question goes to, I guess we'll start with Dr. Loader. Are there any policy changes or advocacy efforts that you are currently watching?
Yes, fortunately, the Reproductive Health Act is in the Michigan legislature right now, which will undo a lot of restrictions around abortion care in the state of Michigan. So it could change laws that require outpatient abortion clinics to meet, outpatient surgical center standards, like having wide hallways or sinks that are unnecessary for clinic-based procedures. It could change insurance coverage and allow for more broad coverage of abortion care amongst private insurers, but also Medicaid and Medicare. It hopefully will take away the 24-hour waiting period. Unfortunately, the act does leave out the need for minors to have parental consent, but that is something that we look forward to potentially in the future. So yeah, I'm really grateful that the last year's election passed Prop 3, which enshrined abortion rights into Michigan state constitution, and that I can continue to practice and even maybe have a more broad practice in the future, because many of these restrictions are harmful to my patients and interfere with care and are unnecessary. So looking forward to those changes in Michigan.
And I'm going to bring that question to everyone else. So Dr. Brandy, if you want to go, and then Pamela after.
You know, I have a list, so I'm going to go down the list. Because this stuff is all important. I hope everyone's paying attention and can think about ways that they can engage in some of this. So some of it's like concepts, and then I have a couple of like actual like political things. So concepts, one big thing that I think more and more people are talking about, but we need to keep talking about it, is decriminalization of anything in pregnancy, anything in general, but I'll focus on pregnancy. So we talk about this a lot in self-managed abortion. We're talking about it for people that are pregnant and continuing pregnancies in certain circumstances, like people like harm reduction for people that are pregnant and using substances. That's decriminalization, meaning that we are trying to minimize their engagement in the criminal penalty system. It's something that I've thought about for a long time, and it's becoming more and more something that we need to be talking about to our whole community of healthcare providers, including medical students that are kind of coming into the profession. So thinking about things like how we document can be a form of harm to people, that hundreds of people are currently being criminally prosecuted based on the fact that they were pregnant and something happened in their pregnancy, and they're being accused of causing an abortion when they may have been having a miscarriage or a stillbirth, or maybe they were having an abortion, and that also should still not be criminalized. So just recognizing that for you future healthcare providers, that the way we document, the way we often call the cops on our patients, like those are things that we need to really interrogate. So is that, I talk a lot in AMSA space about civil disobedience, how that's going to be a conversation. I think that's more and more prevalent as physicians, as other healthcare providers, including students, are making these decisions about, am I going to go and counsel a patient about their options in a state that may prohibit that? Or am I going to send a patient knowingly to another state, or whatever? That we need to start talking about, what are we going to do? How are we going to protect ourselves? Are we going to engage in civil disobedience? And what are the reasons why we may not want to do that for our own protection? Because then we don't have any providers. So that's a whole thing. In the conversation around training, I've been fortunate to be working to help this clinical training nexus across the country. And I'm learning about so many issues that people are facing. We alluded to it earlier. I think Dr. Loder mentioned that there's some states that their programs are state funded, and so they're not paying their residents salary or their benefits for them to go do a rotation for a month somewhere else, because they're state funded. They're worried about the implications there. How are we going to afford it? How are we going to send people across the country? Like, there's so many logistics of trying to figure this out, which is why no one has done it yet. But I think people in pockets are doing all this work, and we need to collaborate on that. Okay. Actual like legislation. This is like a week of advocacy for the HEAL Act. So for those that don't know, it's a federal legislation that is trying to help protect people, regardless of immigration status, to be able to access healthcare. So having coverage for insurance, access for things, including abortion, but really just across the board access to care. PRH did an advocacy day around this, and you think like, well, why is this group that talks a lot about abortion talking about this when it's not abortion centric? And that's the whole point, is that we need to be talking about things on a broader level that are that are integrating all these different issues. We can't talk about abortion justice if we're not talking about immigration justice. So we need to think about some of these ways that we can collaborate with other groups that are doing different work and making sure we're pushing legislation like this. I'll also name the Abortion Justice Act as a thing that probably won't get passed this year, but it's slowly emerging legislation that helps like make insurances cover abortion, protects clinics, protects people that are trying to educate others in the community. So there's lots of work out there. So if you're looking for something to do, I'm sure you will find something that is in the advocacy space to get you interested.
So I'll take building on that. So all of this, every bit of that from both of you. But I'm also, very much so monitoring the state ballot initiatives to enshrine abortion rights into state constitutions. And from a reproductive justice lens, making sure that that they don't perpetuate stigma and perpetuate harm. And also making sure that abortion and just reproductive health and rights aren't being co-opted by people who want to win an election in 2024 and aren't going to be around in 2025 for the teen who isn't able to access abortion, or for the undocumented person who is going to go through 50 hurdles. So I'm watching a lot of that stuff move through, and wearing my MSFC hat, I want to make sure that every single thing that is allegedly going to increase access to abortion increases access to abortion training and education. And so I'm watching Michigan because I think what happened there is really the footprint that I see, the blueprint rather, for what I see in the Midwest and the Upper South, because we all have, I'm from Missouri, I live in Illinois, still a Missourian, and we have TRAP laws, targeted regulations for abortion providers, that are probably not going to fall with a ballot initiative. And so what do we need to be able to do to make the spirit of a constitutional protection for abortion real? And so I've been kind of taking a tour in the press to stimulate that conversation and really talk about what kind of long-term strategy are we going to have. I've also been, taking a study of some of the other countries that have actually decriminalized abortion, just to see kind of how did they get there? What was the path for Ireland? And then what did they encounter after they did it? Because, it was incredibly inspiring to see the green wave in South America, and also to see what was happening in Ireland. But then they don't have enough providers. They don't have enough people who are trained. They don't necessarily have the providers positioned in the right places. And so, you now have Ireland and the Northern Ireland with a right that is hard to access, and that they need to increase. So what can we learn from that? And then also, in the United States, in a country that is looking at spending, millions, $45–50 million per ballot initiative, what is the investment that we can also get guaranteed? That if, as abortion rights people, if we're going to partner with people who have a political agenda, we should be getting something out of this for our work as reproductive justice activists. So if we're going to have 45 million or 50 million go into a state for a ballot initiative, what is the investment that is going to be made in, maternal mortality and, in teen pregnancy support, and all of the various things, in supporting people who are experiencing pregnancy? Because in my home city of St. Louis, the city economically needs a diaper bank and a period products bank. They have an overwhelming need. So when you have a population that can support those two things, then we need to invest in more than abortion clinics. It has to be abortion clinics, and it has to be investing in the communities. And I would like to see a little parity there when we're talking about what would radically change people's lives. So I'm looking at that. As a reproductive justice activist, I'm looking at minimum wage laws that would radically change people's lives, making sure that people who are working fast food and food service and service jobs have protected right to take breaks when they're pregnant, are able to take maternity leave and not have to go back to work a week after they give birth, like many people do. So all of those things are impacting the lives of people who experience pregnancy. And, you know, I love the federal bill that was introduced. I want to say it was by Fetterman, but it was like the school lunch debt. That is a radical, wonderful program or proposal that would change the lives of millions of people and improve their lives. And it's something that we should have done years ago, and we certainly should do as quickly as possible. But those are the kind of policies that I'm looking at when I'm thinking about what would improve health outcomes, but also, you know, make the work that, you know, that providers of reproductive health care do actually have a greater impact, because the lives of their patients are greatly improved.
Absolutely. And Pamela, I know that you work a lot with medical students. So what are some good ways that medical students can start getting involved in some of these advocacy efforts? And any examples that you know of students that you've worked with?
Yeah, you know, I've worked, I actually first got introduced to MSFC through their chapter at Washington University in St. Louis Medical School. So I have a soft spot for that chapter. But I've seen some amazing work be done at the chapter level. We are a grassroots up organization. So the creativity and the energy of our chapter leaders and our student leaders blows me away. But I think, you know, finding out where, if there's a midwifery center, if there's doula center, and how can we just create a panel to talk about the issues impacting our community, that can be a huge benefit to your fellow medical students, and also build a connection that you can build off of. And you know, encouraging your teachers, your professors, and school administrators to have more of a connection and a partnership with those communities, so that they can take that lift off of the students and actually make that part of the curriculum. I think engaging with your, you know, local reproductive rights groups is great, but it's also important to think about, like, what are the other social justice issues facing my community? So, you know, volunteering at the diaper bank, it can be an educational process. It's huge, you know, just seeing the people coming in, hearing their stories, and really seeing, you know, how hard it is for folks to be able to afford diapers, and how limiting it is when you can't. Same thing with period products. I was amazed at how many people miss school because they can't afford period products. So, you know, the various different groups that are always in need of volunteers, that can be a good project. But at the minimum, you can invite community activists into your your world, and you can enter into their world through their activities. And I would also say, for the initiatives that are going around, when you're in a state like Michigan, where they are, trying to get public awareness around a bill, pick up the phone and call your representative and ask them about it. That goes a long way, and so few people do it anymore. But I'm always encouraging medical students to be a voice to elected officials, even if it's not on a piece of active legislation. Picking up the phone and saying that, it's hard for me because of my student debt, is a powerful level of advocacy that you can always do. And they work for you. Somebody's always going to pick up the phone. And I used to do it when I was frustrated and pissed off, and I just call the Senate, and you'd have some interesting conversations. They're like, "You're not from Alaska." I'm like, "No, just calling." But you can do that. You have the right to do that. And particularly when we're talking about medical education, if you are encountering issues in medical education, if you have concerns and fears around residency in a state that has an abortion ban, let people who are policymakers know. After the Dobbs decision, I had amazing, legislators reach out to me in really good states saying, what can we do to help people access training and learning? And many of the hurdles that Dr. Brandy said and Dr. Loader were talking about, the hurdles, the bureaucracy of being able to train and get those clinic hours in a different state are things that can be addressed through policy changes. But these legislators have no idea, and they're not hearing from a lot of folks who just assume that somebody's already fixed it. They haven't, and they need to hear from you about your experience, what's hard, because we're in the middle of a physician shortage in so many areas, but particularly in the states with abortion bans. So the hook is that if they expect people to go into the profession of medicine, then they need to understand that it needs to be shored up and strengthened and improved. There are certain things that could change, just like any other profession, and that they, the same powers that let them pass regressive regulations and restrictions actually could empower them to make it easier for us to have more providers of abortion care, and then also for people of varying backgrounds and experiences to become clinicians in their state.
Such valuable advice. Dr. Loader, do you have any advice for medical students who want to get involved?
Yeah, I've had a few students get involved in different ways. So last year, several students collected signatures for Prop 3, which was awesome and a timely thing to do. My current student who's doing an OA elective with us has done both work with our ACOG's district in Michigan on the Advocacy Day, and has gone to ACOG CLC to learn more about advocacy. And then I've also had students engage with, more local reproductive justice organizations and do work there. One organization in Ann Arbor has been working on a doula project for women who are incarcerated at our prison and pregnant. And so supporting people in their pregnancy, during childbirth, and after. And that's something that, doesn't require a lot of clinical skills and just requires support and time, and is a really great thing that students can get involved with. So I think there's a lot of different areas to get involved, but those are some ideas and some things my students have been doing.
Wonderful. And Dr. Brandy, I'll ask you the same question.
Sure. I mean, I would second all the things already mentioned. I'm trying to think of anything additional. I guess just a couple of comments, I guess, of things people can do. Well, I guess even before that, I just want to recognize that I know everyone is busy. I know that things are hard and you got stuff to do. You got tests to study for, you got clinical work, you're in the OR till late. There are always things that you can do. And not only should you do them because you're a good person and you care about social justice, you should also make sure you put them on your CV and talk about them in your interviews. So that way you also get that benefit if you feel like you need that extra boost to do it. Like it'll be on your CV. You can add that to your ERAS or whatever the new program will be for your different specialty. So it's okay. So things you can do. I think a lot of things were already mentioned. Calling your senators and your representatives. I'm an introvert. I hate calling people. And so I will do the opposite of what Pamela recommends. I will call them at like 9, 10 o'clock at night when no one is in the office and leave them a message. And I always tell people to do this by phone, don't email, because they'll probably read emails maybe at some point eventually, but they always have to listen to all the calls and refer them to the representative. So please do that, particularly around issues around education, because I think people aren't talking about that as much. Similarly, in the media, everyone I talk to that's a reporter wants to talk to a med student about how things are. So consider talking to groups like MSFC, ACOG, other orgs, because they're looking for students to speak out on this issue. And I do want to name the fact that I think some schools are prohibiting people's speech, that I think medical students are afraid to speak out because they're worried about repercussions, and that's a real thing, and that's something that you have to consider as you're being part of this. Other things to do. I was involved with a med student group that started a doula program for abortion care. So that's something that you could do. Think about all the issues that are interconnected. Like Pamela was mentioning, some things I was thinking about is starting a community garden or food bank. Think about some of the things that impacts people's day-to-day lives and what are the ways that you can contribute to that. So I like community gardens, I think is a nice thing. And just being a support in any way that you can. Go to an abortion clinic, be an escort in an abortion clinic. There's so many things you can do. And if you don't know what to do, you can always reach out to groups like AMSA, Med Students for Choice, and we will find you something to do. We will connect you with people. So just like let us know, and we're happy to help figure that out for you.
I'm just going to very briefly say that we want to mention that Loretta Ross had an emergency this evening. She's fine. Everything's fine. We hope to have her back for a future event, but we just wanted to acknowledge that. And as she is one of the founders of the RJ movement, we definitely were hoping she would be here, but we will see her again soon. And Anna, I will pass it along to you.
Well, thank you all so much. I'm going to leave the space for some concluding remarks from our panelists. So if there's someone in particular that wants to go first, otherwise I can just call on someone as well. So we can maybe go with Pamela if you have any concluding remarks, and then we can go from there.
Sure. So thank you for this opportunity. This has been a real pleasure. And I hope that that people listening and watching have enjoyed it as much as I have. I think that, Medical Students for Choice is really poised to meet the moment. And so we welcome student leaders and the support of the broader medical education community. We do have a joint petition with our friends at AMSA that we will be circulating soon. And it is a petition that is going out to the LCME, basically closing the loophole of them not having abortion and family planning as a criteria for accreditation. So making that demand that they fix that so that we can have some sort of standard medical school to medical school. Rather than have it be so hit or miss. And obviously it's an important thing that they need to catch up to. So I'm excited about that. I'm excited about working in coalition and partnership with AMSA and what that means for the work that we can do, making it more full, more people, better, RJ, because we're actually in more communities. And I encourage folks to, join an organization. And I think that these are two fantastic examples of organizations that really do support the grassroots organizing. We don't dictate to our chapters. And we have a lot of resources, including legal resources, that can help you if you're encountering any hurdles to your educational journey. So, stay tuned, and I appreciate just everybody and all of the wisdom that I've learned today.
Thank you so much, Pamela. And Dr. Brandy.
Sure. I have no remarks planned, so I'm trying to think. I would second that. It's been really lovely to have this conversation with you all. I've learned a lot, and I'm thinking a lot about what are some other things that I can do to be a good member of our community and our movement. So thank you for those inspirations. I think for me, and I say this a lot, is that I think medical students, pre-med students don't really recognize how much power they have in the system. And it's really important just to continue to reiterate that and name that you may feel helpless sometimes. You may feel like you're just like the product of whatever med school you're in or whatever system that you're in. But you have the ability to make change in your system. But we've given you a couple examples already today to bring outside speakers in, to look for those community partners that you can engage with. Think about what you can build in your school that will help your community and help further the movements of social and reproductive justice. So there's a lot that can be done. Also, just recognizing your power in the system. Challenge why there is no lecture on abortion, or why is it stigmatized, or you have the ability as a student to ask those questions because you should be asking those questions. And you have a big stake in your own education. And I don't want to put the onus on you, but I think it's important to think about what can you do to make that change, not just for you, but for the tens of other med students that are going to come in the next year that need that education. So just be brave and think about what you can do to help make that change.
Love that. And then we'll conclude with Dr. Loader here as well.
Thank you. It's been such an honor to be with all of the panelists today and those who are listening. I think it's one thing about reproductive justice is that, students and learners are entering a health profession that has perpetuated injustice. And it's, challenging to think about that and think about one's role in injustice. Part of reproductive justice work is to have that reflection on oneself and one's own practices, but it's also important to find the like-minded people in your class or in a different class to discuss that, that reflection and think about what you can do in terms of advocacy or enacting change, whether that's in your clinic, in your hospital, or in your state. And it's also important for you to have that self-empathy and realize you are studying really hard. You're working, towards a very challenging goal, and we don't always do things the way we wish we had. And that's how I came into reproductive justice work, is realizing I made, a huge mistake with a patient, and reflecting on that and discussing that and learning about reproductive justice and how I could, combat some of the practices I had learned. So yeah, be kind to yourself and reflect. Thank you.
Oh, what a wonderful remark to close up on. So as we conclude today with this inspiring and insightful panel, I want to express my sincerest gratitude to all of you, all of the amazing panelists, for sharing their expertise and their perspectives, and then to all of you who has also joined us on the live stream. Just want to throw out some quick reminders as well. National Primary Care Week is coming up October 2nd through the 6th, and we will be having a special reproductive health focused session on Tuesday, October 3rd from 8 to 9 p.m. Eastern. So be on the lookout for that. Otherwise, I hope everyone has a wonderful night and to take care of yourself.